1 in 7 mothers develops postpartum depression, and yet, according to Wendy Davis from Postpartum Support International, even medical professionals are often not properly trained to recognize or discuss it. That's not a small gap. That's a systemic blind spot affecting millions of families. Today, we're getting into what postpartum depression actually is at the level of the body, the hormones, the neurotransmitters, the brain, and then we're asking how all of that chemistry connects to what mothers actually feel and live through. By the end of this episode, you'll understand the difference between baby blues and clinical PPD, why the body's chemical crash after birth is more dramatic than most people realize, and why treating just one side of this, either the biology or the emotion, misses the full picture. Joining me to dig into all of this is someone who has spent serious time in the research on this topic. Let's get into it, starting with something that I think a lot of people genuinely don't know. What is actually happening in the body in those first days after giving birth?
So the first thing to understand is that childbirth triggers one of the most dramatic hormonal shifts the human body ever goes through. During pregnancy, estrogen and progesterone are at extraordinarily high levels. They're essentially flooding the system to support the baby's development. And then the moment the baby is born, those levels don't just drop. They fall off a cliff.
How steep are we talking?
Estradiol, which is the primary form of estrogen, decreases by over 100-fold within just days of delivery. That's not a gradual adjustment. That's a near total withdrawal of a hormone that was actively supporting mood regulation, serotonin production, and cognitive function.
Wait, 100-fold? That's not a dip. That's basically the floor dropping out.
Exactly. And progesterone does the same thing. It plummets from those high pregnancy levels. Now, progesterone is important because it stimulates GABA receptors in the brain. GABA is essentially the brain's calming system. So when progesterone crashes, you lose that calming effect almost overnight. And at the same time, because estrogen was helping boost serotonin and dopamine, your mood stabilizing and motivation chemicals, losing estrogen means those systems take a hit too.
So it's not just one chemical going haywire, it's like multiple systems losing their support structure simultaneously.
That's a really good way to put it. And this is why up to 80% of new mothers experience what's called the baby blues. Mood swings, tearfulness, irritability, trouble sleeping in those first 1 to 2 weeks. The body is scrambling to recalibrate.
Okay, so where does postpartum depression come in? Because baby blues and PPD get used almost interchangeably sometimes, and I don't think that's accurate.
They're really not the same thing. Baby blues are temporary. They typically resolve within 10 to 14 days as the body starts to find a new hormonal baseline. Postpartum depression is a different beast. According to Mayo Clinic, PPD symptoms are more intense, last longer, and can interfere with a mother's ability to care for her baby and handle daily life. We're talking about things like severe mood swings, difficulty bonding with the baby, withdrawing from family and friends, intense feelings of worthlessness or guilt, and in serious cases, thoughts of harming oneself or the baby.
And PPD affects about 1 in 7 mothers, right?
That's right. And here's something that surprises a lot of people. Although PPD is diagnosed after childbirth, symptoms can actually begin during pregnancy. So the idea that it's purely a post-birth phenomenon isn't quite right. The perinatal mental health field actually defines the window much more broadly than the standard medical definition.
That's interesting because there's actually a real debate about how long the postpartum period even lasts. I was reading about this. Some medical experts say 6 to 8 weeks. Others say up to a year.
Yeah, and that ambiguity has real consequences. The American College of Obstetricians and Gynecologists considers postpartum care to extend to 12 weeks. The DSM, the diagnostic manual, uses a 4 to 6 week window. But mental health specialists in the perinatal field push back on those narrow definitions because the emotional and neurological recovery from childbirth doesn't follow a neat calendar.
And that definitional confusion can mean women who are still struggling at, say, month 4 or 5 don't get the support they need because technically they're past the window.
Exactly. And it connects to a broader cultural problem. Wendy Davis from Postpartum Support International put it really directly. She said, quote, "The reason we don't know more about it is that we compartmentalize mental health away from physical health, and in medical school we're not properly trained. That gap in training means the people most likely to see a struggling mother early, OBs, nurses, pediatricians, often aren't equipped to have that conversation."
That quote really lands, because it's not just about individual doctors, it's a structural thing baked into how we train people.
And the consequences of that gap are serious. Women experiencing postpartum mental health disorders often don't recognize their own symptoms. They mistake depression and anxiety for personal failure, like they're just not cut out for motherhood, when what's actually happening is a complex neurobiological event.
Let's stay on the biology for a second, because I want to understand the full picture of what's happening chemically. We've talked about estrogen and progesterone. What about cortisol and oxytocin? Because those come up a lot in this conversation.
Great question. Cortisol is the body's primary stress hormone, and during pregnancy it's elevated. After birth, it's supposed to normalize, but here's the thing. Disrupted sleep, physical recovery, and the demands of caring for a newborn can keep cortisol patterns irregular, and that affects mood, memory, and decision-making. So even as the reproductive hormones are crashing, the stress system is being constantly activated by the realities of new parenthood.
So the biology and the circumstances are kind of compounding each other.
Precisely. And then there's oxytocin, often called the love hormone. It's released during breastfeeding and is essential for bonding and milk letdown. It's also been hypothesized to play a role in postpartum depression. But a systematic review from Emory University published in Psychoneuroendocrinology found that the relationship between oxytocin and PPD is actually quite complex and not fully understood yet. The data isn't clean enough to say oxytocin definitively protects against or contributes to PPD.
So even the so-called bonding hormone has a complicated relationship with postpartum mental health. That's kind of humbling, like the body isn't just running a simple program here.
Not at all. And that's actually one of the most important things to understand about PPD. A review from Johns Hopkins School of Medicine and Tufts University, published in Frontiers in Neuroendocrinology, laid out just how many different mechanisms are potentially involved. Neuroendocrine changes, neuroinflammation, neurotransmitter alterations, circuit dysfunction, and even genetics and epigenetics. It's not one thing going wrong. It's a convergence of multiple systems.
Neuroinflammation is one I don't hear talked about much in this context. What's the role of inflammation?
So a massive systematic review from UC Irvine and UCLA, covering 199 investigations of over 151,000 women, found that among the strongest biological predictors of PPD are hypothalamic pituitary adrenal axis dysregulation, inflammatory processes, and genetic vulnerabilities. The HPA axis is basically the body's central stress response system. When it's dysregulated, it can amplify emotional reactivity and make it harder to recover from stress. And inflammation, which can be triggered by the physical trauma of childbirth, has been increasingly linked to depressive symptoms more broadly.
So we're talking about the immune system, the stress system, the hormonal system, and the neurotransmitter system, all potentially contributing. That's a lot of moving parts.
And what makes it even more complex is that not all of these systems are equally active in every woman who develops PPD. A 2026 study published in Nature actually used brain imaging and molecular data to identify two distinct neurobiological subtypes of postpartum depression, with different structural brain profiles. So what's happening chemically in one mother's brain may be fundamentally different from another's, even if they're presenting with similar emotional symptoms.
Wait, two distinct subtypes? So PPD isn't even one condition in the neurological sense?
That's what the emerging research suggests. And it has huge implications for treatment. If we're treating PPD as a single uniform condition, we might be missing the mark for a significant portion of women whose underlying biology looks completely different.
That reframes the whole conversation. Because right now, the standard treatment is often SSRIs and therapy. But if the neurobiological picture varies that much, a one-size-fits-all approach seems limited.
Exactly. And this is where the emotional and psychosocial layer becomes just as important as the chemical one. Because even if you address the hormonal crash, the lived experience of PPD involves things that hormones alone can't explain.
Let's go there. What does the research actually say about what mothers experience emotionally?
A 2025 qualitative study published in BMC Pregnancy and Childbirth interviewed 21 mothers diagnosed with postpartum depression. And what came through was really striking. These women described feelings of inadequacy, regret, self-neglect, and genuine difficulty coping with the identity shift of becoming a mother. Traumatic birth experiences and risky pregnancies were additional triggers, and they expressed a strong need for emotional support from spouses, families, and healthcare professionals, support that often wasn't there.
So the emotional experience isn't just a downstream effect of the hormones. It has its own texture, its own specific content.
Right. And a 2024 meta-synthesis in PLOS ONE, which pulled together 28 qualitative studies, identified three core themes in the psychological experience of PPD: negative physical and psychological experiences, role transitions discomfort, and lack of relevant support. That role transition piece is really significant. Becoming a mother is a profound identity shift, and when that shift happens alongside a neurochemical crisis, the two things amplify each other.
And yet the biological and psychosocial research literatures are largely separate, right? Like they're not talking to each other much.
That's one of the most important critiques in the field. The UC Irvine and UCLA systematic review explicitly called for integration. They noted that the biological and psychosocial literatures are largely distinct and that few studies provide integrative analyses, which means we have a lot of knowledge about the chemistry and a lot of knowledge about the emotional experience, but not nearly enough research that looks at both together.
And that gap in research mirrors the gap in how we talk about it culturally. Like people either say it's just hormones or they say she's struggling emotionally, and both framings are incomplete.
Completely. And that framing problem has real stakes. When women hear it's just hormones, it can feel dismissive, like their suffering isn't real or serious. But when the conversation is only about emotional experience without acknowledging the biological reality, it can inadvertently reinforce the idea that PPD is a personal failing or a weakness. Mayo Clinic is actually pretty direct about this. They state explicitly that postpartum depression is not a character flaw or a weakness. It's sometimes simply a complication of giving birth.
That framing matters so much, because the research on lived experience shows that women are already blaming themselves, feeling inadequate, feeling like they're not good mothers. And if the cultural message reinforces that, it delays help seeking.
And delayed help seeking has serious consequences. The Lindsay Clancy case, which has been in the news recently, has put this into very sharp relief. Her defense has argued that she had postpartum depression and psychosis at the time of the killings, compounded by what her attorney called a lack of adequate medical care. Whatever the legal outcome, the case has forced a public conversation about how poorly understood postpartum mental health conditions are, even in medical and legal systems.
It's a tragic and extreme case, but it does illustrate what's at stake when these conditions go unrecognized or undertreated.
And it's not just extreme cases. 1 in 5 women experience clinical mental health symptoms during pregnancy and postpartum. That's a statistic from the reporting around that case. That's a massive number. And yet the systems designed to catch and support these women are often inadequate.
So what does better support actually look like? Is there research on what works?
There is, and some of it is really encouraging. Research published in August 2026 from the University of Rochester Medical Center, now being led by Dr. Marika Toscano at Johns Hopkins, found that offering evidence-based mental health support to women during high-risk pregnancy hospitalizations can actually help prevent postpartum depression. Women who participated in what they called the ROSE intervention experienced fewer PPD symptoms in the first 6 weeks after childbirth compared to those receiving usual care.
So intervening before birth, not waiting for the crisis to develop, actually changes outcomes.
That's the key finding. And Dr. Ellen Polishuk, who directs the Program for Mental Health and Gender Wellness in Obstetrics and Gynecology, put it plainly. We don't want to wait for people to recognize they have a problem and ask for help. That proactive stance is a real shift from how postpartum care has traditionally been structured.
Because traditionally it's reactive. You wait for symptoms to become severe enough that someone seeks help, by which point a lot of damage may already be done.
Exactly. And for women hospitalized during high-risk pregnancies, the risk of developing PPD is roughly twice that of the general pregnant population. So those hospital stays are actually a critical window, a moment when you have access to a vulnerable population and can offer support before the crisis hits.
That's a really different way of thinking about it, the hospital stay as an opportunity rather than just a medical event.
And it also speaks to the equity dimension. Preventive mental health care isn't always accessible, especially for women whose prenatal care is disrupted by an unexpected hospitalization. Making support proactive rather than reactive is a step toward making that care more equitable.
I want to go back to something you said earlier, that hormone levels alone don't predict who will develop PPD, because I think that's actually a really underappreciated point. Every woman who gives birth goes through that hormonal crash, but not every woman develops PPD.
That's the central puzzle. The hormonal shift is universal. The depression is not, which tells us that the chemical response is necessary but not sufficient. Some women appear to be more sensitive to those hormonal fluctuations, and that sensitivity may be shaped by genetics, by prior mental health history, by the quality of social support, by the circumstances of the birth itself. It's a genuinely complex interaction.
So the chemistry sets the stage, but the emotional and social context determines whether the play becomes a tragedy.
That's a really apt way to frame it. And it's why the call for integration in the research is so important. If you only study the biology, you miss the factors that determine vulnerability. If you only study the emotional experience, you miss the neurobiological reality that's shaping that experience from the inside.
And for someone listening who either has experienced PPD or knows someone who has, what does understanding both sides actually change?
It changes the story you tell yourself about what's happening. If you understand that your brain's calming system just lost its primary support, that your serotonin and dopamine pathways are disrupted, that your stress system is dysregulated, then the feelings of overwhelm and inadequacy aren't evidence that you're failing. They're evidence that your body is going through something genuinely hard. That reframe can be the difference between seeking help and suffering in silence.
And on the flip side, understanding the emotional layer, the identity shift, the need for support, the role transition, means that medication alone isn't the full answer either.
Right. Treatment options include therapy, medication like SSRIs, and lifestyle changes. But the research on lived experience makes clear that social support is not optional. Mothers in the qualitative studies described a strong need for emotional support from spouses, families, and healthcare professionals. That's not a soft finding. That's a clinical need.
So when you step back from everything we've covered today, here's what this really comes down to. Postpartum depression is not a simple story. It's not just hormones, and it's not just emotions. It's both, and they're deeply entangled.
And the research is starting to reflect that complexity. The 2026 Nature study identifying 2 distinct neurobiological subtypes of PPD is a signal that we're moving toward more personalized understanding. The early intervention research from Johns Hopkins and Rochester shows that proactive support works. The qualitative research gives us the human texture of what this condition actually feels like from the inside.
What I keep coming back to is that 100-fold drop in estrogen. That's the kind of number that should make anyone pause. If any other organ in the body lost 99% of its primary support chemical in a matter of days, we'd treat it as a medical emergency. And yet the brain going through that same withdrawal is still too often framed as a personal struggle.
That's the reframe that needs to happen at a cultural level. The biology is real, the emotional experience is real, and neither one cancels out the other. They're both part of the same story.
And understanding that story, really understanding it, is what makes it possible to ask for help, to offer help, and to build systems that actually catch people before they fall.
Exactly. And the research is clear that early proactive support makes a measurable difference. The window matters, the conversation matters, and knowing what's actually happening in the body and in the mind is where that conversation has to start.
We started this episode with a number, 1 in 7. And here's what that number actually means. It means that in almost every room you walk into, someone has been through this or is close to someone who has. The chemistry is real, the emotional weight is real, and the gap between what we know and what we do about it is still too wide. If this episode made you think differently about postpartum depression, share it with someone who needs to hear it.